While many of us are anxious for a return to life as we knew it before COVID-19, it is becoming increasingly evident that it will be some time before we see an end to this pandemic. Meanwhile, it's important for us all to continue doing our part to decrease the spread of the virus by wearing a mask, practicing good hygiene and social distancing, and limiting exposure to people outside of our respective households. As we wait for a few more people to join, I'd like to introduce myself and tell you a little bit more about the Center for African American Health. My name is Deidre Johnson, and I am the CEO and Executive Director of the Center. For those of you who may be unfamiliar with our work, we have been in the community for more than 20 years with a focus and commitment to improving the health and well-being of Metro Denver's African American community. As we move through today's session, please feel free to type your questions in the comment area, and we'll address them if time permits. So the prevalence of the news related to COVID-19 and vaccine distribution has sparked conversations related to the health inequities in Black and Brown communities. This pandemic highlighted the fact that long-standing inequities have largely contributed to making us to affecting us with regard to the virus. In addition to underlying chronic health issues, a recent publication issued by the Mayo Clinic lists barriers to adequate health care, certain occupation, dense living conditions, and the stress of dealing with racial discrimination as factors that increase the risk of severe illness with COVID-19. Now more than ever, it's imperative that healthcare providers establish a trusting relationship with the African American community and provide patient-centered, culturally competent care. My guest today joins us from Cleveland, Ohio. Dr. Greg Hall is a primary care physician with over 20 years of experience, who specializes in the healthcare of African Americans. In addition to his practice, Dr. Hall is an educator and author of a book published last year entitled Patient-Centered Clinical Care for African Americans. Thank you so much for joining us today, Dr. Hall.
Thank you so much for having me. It's great honor.
So you have a wealth of education and experience in the medical community. Can you provide our viewers with an overview of your background and the impetus for your recent publication?
Yeah, sure. I'm an internal medicine physician, primary care physician here in Cleveland. I see patients 18 and over. Because I'm based in the city, probably 90% of my practice is African American. And part of what I do, I work at the medical school close by. I still go to the hospital. I still go to the nursing home. So I see a lot of people in the course of the day. In seeing the patients, and I also more recently, within the last, well, not more recently, probably like 20 years ago, I was appointed to the Ohio Commission on Minority Health. And as part of that, I was vice chair for many years and then chairman the last few years up until 2018. And that really opened my eyes to health disparities and research data. And as I started to do research really for presentations at the commission and across the state, I started learning about differences in the clinical care of African Americans. The more obvious ones were hypertension, the medications that you use for high blood pressure in African Americans is different than the medications that you would use. The preferred medications are different than what you would use in a white American, for example, or a Hispanic Latino, for example. So it struck me that I sort of knew through treating Black patients and them not responding to one set of medicines versus responding to this other set of medicines, I sort of navigated to the right medication sort of accidentally, and then realized there was this research that was done that showed that what I was doing had really already been proven, but the research was done and then it was just like put on the shelf, right? And so then I found more and more research about, differences like we're learning about now with vitamin D levels in African Americans and vitamin C levels and laboratory differences, low white blood cell counts, lower thyroid counts. And so there was enough things that I said, I started educating my patients on my website, but then I thought I need to go upstream and really educate the providers. And since I teach medical students and medical residents, I said, the key is not so much educating Black people on how to educate their doctors on how to treat them, but really to educate the doctors. And so my book is not really for patients to buy, it's for physicians to buy, so they can learn sort of best practices in treating Black patients.
That's fantastic because it helps promote that systemic change that we really need to see.
Absolutely.
So it's well known that people of color are less likely to trust healthcare providers. And as a result, they don't often receive the quality of care they need and deserve. So in your opinion, what can be done to improve this dynamic?
Right, and it's critical. The whole first chapter of my book is on trust. Establishing trust for patients. Physicians need to know. The first thing the physicians need to know that this trust issue happens. So in Cleveland, there are a lot of physicians that come from India or come from Europe, and their patients just revere physicians. So whatever the physician says, the patient does. And then these type people who grew up in that environment then comes to United States and sees an African-American patient who, because of a verified history of abuse and, grave robbing and experimentation and, 44 studies show 44% of African-Americans don't trust providers, whether you're Black, white, green, whatever. But there are ways to gain trust. First off, now as a Black physician, I can gain the trust of a Black patient faster than a white physician, but a white physician can also gain that trust, right? And so if you don't know that there's trust issues, you just think, I decree you take this and then walk out the exam room. That's why we're going to see the disparities that we see, because people don't do that. I took my mother-in-law for an appointment because my wife couldn't do it. And I sat in the room, just being the supportive to the patient and listened to everything. I thought the person was nice and caring and everything, but it was a white lady. And we got in the car and my mother-in-law said, I'm not doing any of that stuff. And I thought, wow, how many people walk out of the exam room with me and get in the car and say, I'm not doing any of that stuff? And because even though I thought the lady was nice and everything, my mother, she didn't know her. She didn't know her from Adam. And so she's like, I'm not doing that. And so that duplicated really across the country, across a whole lot of people. And the provider certainly probably thought she had done a great job. I thought she'd done a great job, but in reality, there was a complete disconnect between her. And so educating the providers about knowing that there's trust issues, and then having the patients know that, in order to get the best care, you've got to be able to take some advice. You can't go online and learn everything you need to know about diabetes. You're going to have to be able to find a provider that you trust and hope to trust the advice that they give you. So it's a two-way street. It's a relationship, right?
Definitely. It's interesting because you have the challenge of the physician trying to figure out the best way to create trust. You have the challenge of being that patient. I've been in this scenario years ago where I like to ask questions, and I was told by a potential physician, why are you reading too much? Why are you asking these questions? And I just went to the next and found a good match for me. But it really is, I always tell folks, you can't help people that you really can't see or don't know.
Right. And people also look for people that look like them. And so I have patients that will Google Black doctor or African-American doctor in Cleveland, and then I show up on the first page because they want a Black doctor. A lot of African-American men want an African-American male doctor. Younger African-American women want an African-American woman doctor. And so as much as we can do as a society to encourage, to bring along that next generation of physicians and bring it higher than 4%. We're 13% of the population, yet we've only got 4 to 5% of the doctors, and the number of that, and there's more women than men, amongst African Americans. That's going to make it hard for people to trust.
So can you talk about your experience as a physician who has witnessed health inequities in Black and brown communities firsthand, and the effects of poorly controlled chronic diseases such as diabetes, hypertension, and COPD?
Sure. I tell a lot of patients that come to see me with diabetes and hypertension, and they frequently think it's something that they're doing wrong. I'm not eating right. I'm not exercising. I'm not doing whatever it is. And if I were to do those things, the diabetes would go away, the hypertension would go away. And that's a misconception, that they're more than 9 out of 10, 99 out of 100 you're going to have diabetes if you had a perfect diet, right? You're going to have hypertension because of something that's inherited. And I tell people, you know, I've got 2 brothers with diabetes. My father, diabetes runs in my family, so I can't avoid that. I can probably kick it down the road if I watch what I eat and do some things, or maybe if I became vegetarian, strict, you know, and had someone follow me around, maybe I could kick it down the road a little bit further. But if I live long enough, the genes are there for me to have diabetes and hypertension. Quiet as it's kept. And so just not having the benefit of medication. So medication is what gets us out of. That's what makes your blood sugar is normal. If your blood sugar is normal. So diabetes is the #1 cause of blindness, #1 cause of kidney failure, #1 cause of amputations, right? So if you have diabetes that's uncontrolled, blindness, kidney failure, amputations, infections, premature death are all in your future, right? If you have it controlled, it's as if you're not diabetic to a certain extent, not completely true, but to a great extent, right? So same thing with hypertension. If your blood pressure is high, you're at increased risk for stroke and heart attack. If your blood pressure is normal, you're at a dramatically decreased risk for, you know, stroke or heart attack or aneurysm, rupture, all of those things. And so you have hypertension and you just say, well, if I use less salt, or if I didn't eat fried food, or if I walked more, the hypertension would go away. In my practice, that's not what happens. It's the medication that makes it go away. And so finally, what I tell my patients, when I was born in 1961, the life expectancy in 1960 for an African-American male like myself is 59, was 59. That was the life expectancy in 1960, 59. So in 1960, there was no medications for hypertension for African Americans. There was no dialysis. There was no medications for diabetes for the majority of African Americans. And so they died at 59 or 60. And so what's the difference between 1960 and 2021? We've got medicine for hypertension. We've got medicine for diabetes. We've got dialysis. And so that's why our life expectancy now in the mid 70s, right? So if you say, I don't believe in medicine, I don't believe in these things and that things, you basically go back to 1960. You know, your life expectancy goes to the point where there was no medication for these things, when there wasn't dialysis, when there wasn't a kidney transplant. That may be a long answer, but that's the best I could do.
No, I see what you're saying, because the environment kind of changes with the tools that we have to help us. But, you know, there are folks who have fantastic stories about, you know, once I lost weight, got physically active, and really took good care of myself, my A1C went down, my blood pressure resolved. What are your thoughts?
Oh, it's true. You know, I have people with bariatric surgery. You know, then they have the weight loss surgery, and I've got a number of people who've lost 120 pounds, and their A1C went down, their blood pressure went down. Absolutely, it goes down. But both, you know, and that's a positive thing. So weight loss, I'm not trying to discourage those things, and those stories are true. But, you know, kind of to my patients, maybe it's my patients in Cleveland, that's a really small percentage. The rest of them are saying they're going to do something that when they come back 6 months later, they haven't done. You see what I'm saying? Right. I'm going to start doing this. When they come back, well, did you do that? Well, no. Well, how about take some blood pressure medicine until you do that, right? You know, right. Let's take your diabetes medicine until you lose 120 pounds. Or I can monitor it as you go down, because the vast majority kind of don't do it in anticipation of this epiphany that they're going to have. And then they're going to kick in and be like, you know, Mr. or Mrs. Healthy. And then unfortunately, we don't see that.
Yeah, lifestyle, healthy habits are actually quite hard.
They're hard. It's hard for me. They're hard for me. Hard for everybody.
So what advice can you give viewers about developing a trusting relationship with a physician? And how can you determine whether a provider is a good fit? You know, for me, it's if they'll talk to me and answer my questions.
Right. Do they listen? Do they have the time, you know, for you? Some people don't have the time, right? And I judge people that way too. If you don't have the time for me, then let me find someone who has the time for you. I mean, it's now I might be late, to a certain extent, but once you get there, I have the time. And and what sort of access for everyone I see in my office, I call them when their labs come back. I call them on their cell phone and go over their labs if they answer. So if they have any follow-up questions or any issues, they can kind of get back to me. And that's a best practice. That's not just me. That's something that you should be able to talk to your doctor on the phone. And now with the COVID, we get reimbursed for phone calls. We get reimbursed for telemedicine. And so I'm way happier to do something if I can get reimbursed, as part of my job, right?
Right.
I used to have patients that would call me Friday at 5 o'clock, and I'm like, wow, they waited until the end of the week, and then I don't get reimbursed, and then it can be difficult. But now with under telemedicine and these new rules because of the pandemic, you should have more access, albeit electronic, to someone who can kind of talk to you, and then electronically prescribe medicine if it's not controlled. It's just, I think you should know that you come to the table, as a patient, you're a valuable thing. And it's a relationship that should be equal. It's not just that they take you on and then you're just this little thing and it's a big doctor. You should feel like you're a member of a team, because if you don't, you're not going to do what the person asks, and you're really wasting really everyone's time.
So any advice on, and this is one of the questions that came in, any advice on how patients can become better health advocates for themselves and for family members in clinical health settings?
Well, it's encouraging for me to have someone come in when we kind of come out of the pandemic, to have a husband and a wife come in, because if I talk to, an African-American male about his diet and his wife does all the cooking, I'm wasting my time, because he says, I just cook what she gives me. You know what I mean? And so many times I had another couple where the husband cooked all the time, and he was using margarine like you wouldn't believe. Like a stick of margarine went into a skillet, and I was like, a stick of margarine, things that I couldn't even conceive of. And their cholesterol was really high. And he did that every time he made vegetables. It was a stick of margarine. Oleo is what he called it. And so when we talked about that together, and when they came back 3 months later, both of their cholesterols had dropped like 40 points, all because she was just eating, and she wasn't trying to be picky when he ate, and she liked his food, and she ate whatever he put in front of him. So having, going to the doctor when you're allowed to with your loved one, I think is a useful thing if you're allowed in. And we have restrictions about talking to relatives versus when you can talk to the patient, have the patient talk to the relative. But certainly if people can get on the phone, that's not a problem. You should be happy with your doctor. If you're happy with your, people that you deal with and that they're getting paid for their time, you should be happy with them. And if you're not happy with them, you should find someone that you are happy with.
Thank you. Mm-hmm. So it's the new year. Many of us are trying to honor resolutions to exercise, eat healthy, but we often overlook the importance of quality sleep. Please discuss your findings related to sleep apnea in the African American community.
Well, sleep apnea is very widespread, and it's a lot of people have it and don't know. So I had sleep apnea and did not know it. Sleep apnea is much more common in people that are obese, and African Americans are much more obese compared to white Americans or Asian Americans, right? And so that increased obesity causes increased obstructive sleep apnea. That's the technical term for it, because of the increased area in your neck. And when you sleep, your tongue kind of goes back and it blocks the airway, okay? And that blocking the airway causes your brain to say, wake up and breathe, wake up, move your tongue forward and breathe. And then when you do that, you don't get REM sleep, you don't get deep sleep or restorative sleep. And so you wake up very exhausted and tired and sleepy, and people who feel like they need to nap during the day, that's the issue. But it also does a whole slew of other bad things. It makes your diabetes worse, harder to control. It drives up blood pressure. It drives up your risk for sudden death from a heart arrhythmia, a heart rhythm problem. It drives up just a ton of things. And so sleep apnea, it's under-recognized as a cause for a whole lot of things in terms of people not just feeling fatigued, feeling depressed. I found many people that are depressed and fatigued have sleep apnea. Sleep apnea is actually at the end of that. And then after we diagnose sleep apnea, which is done with the sleep study, we prescribe CPAP, which is a mask that goes on, that actually forces the air into your lungs and doesn't allow your palate to obstruct, and allows you to get a good night's sleep. And so when I had sleep apnea before it was diagnosed, I could sleep 9-10 hours and still wake up feeling like hell and be tired all day. And it just just go to sleep. And once I got it, I could go to bed at midnight and wake up at 6:30 feeling like a million. I wrote this book after I got treatment for sleep apnea because I had so many more hours where I was alert and active and able to do it. But unfortunately, African Americans are more apt not to want to have a CPAP mask on. It's not sexy. I mean, to have someone laying there with a hose coming out of their mouth, that's not sexy, but it's great to feel good during the day when you're going through the thing. And so people sort of reject the idea of a CPAP mask before they try it and see how much benefit it can give you. And there's a little learning curve to it. I mean, I had to get used to it. It's like having really strong air blowing in your face. You kind of have to catch your breath. But now I can sit and watch TV with it on. So let's just be aware that that's a potential cause. Remind your physician that what about sleep apnea? Patients will say, what about so and so? I'm like, oh, that's a good point. Let's check that. So sort of bring that up as a possibility for if you're tired, if you're sleepy, if you've got chest pain, if your blood pressure up. My blood pressure went down 20 points when I started wearing a CPAP machine because the stress on my heart was significant. So just sort of be aware of that. And it's very widespread in the African American community.
I actually have a relative who didn't go with the CPAP, but I guess with a dental mold, it kind of helped do the same thing. It wasn't covered by insurance and it was a lot more expensive, but
well, actually, that's what I went to. I wore the mask, saw that on the internet, and then went to that. And so it's way more comfortable. But it holds you on your teeth, but then it goes into your nose.
Another question: any suggestions on how patients can keep better track of their medical appointments and medication lists?
Well, again, and here in Cleveland, we have this My Chart where people can kind of get online and sign on from wherever to their chart in the hospital system. And so that's coming more widespread as as it sort of electronic medical records sort of, percolate, through the country. And so for us, we just kind of go online and it's just like signing in any other page. You username and password, and then you can see all your medical records. You can see whatever notes you need to see. And so that's the best way, right? But otherwise, I have people who just on an index card, they write their medications down. They write their diagnosis down. I can print up a summary, and many doctors can, of your visit, and people will cut the little part that has their medication list down, because the medication list almost tells the entire story. It wouldn't talk about sleep apnea, but it would tell almost everything else. But just a little slip in your wallet or something on your cell phone, a document, I think that will work.
Thank you. With sleep apnea, can you use the mouthpieces? Okay. So related to what we were talking about earlier, the mouthpieces instead of the CPAP machine, is the mouthpiece equally as effective when it comes to resolving those symptoms?
So let's be clear. The mouthpiece is like a football tooth guard, and it has two little nasal pillows. I'm gonna stick my finger, that sits here, but it holds, or the mouthpiece holds it in place. So you have these two rubber things that go in your nose and blow out, and it blows the air into your nose. So the mouthpiece just keeps it so it doesn't move around, right? So it's not blowing it through your mouth. It's still blowing through your nose, but it's attached to your upper jaw, which doesn't move. And it's very for me, it was much more comfortable than a mask that's set over my nose. I had a patient yesterday that said they like the mask better, to be honest. And my brother has it. He said he likes the mask better, but he tends to say the opposite of what I say anyway.
But you'd say they're both probably equally effective?
Yeah, no, they are equally effective. They're not probably, they are equally effective. But the nose guard is way more comfortable for me. But it is, I have to buy mine myself. But you know, I sleep a third of my life, so I just invest in it.
Well, you know, really, to me, one of the messages that's underscored here, and what you said earlier, we're important, our health is important. I think so often you get in your day-to-day and you think, oh, I'm exhausted, that's like a normal, and it shouldn't be a normal.
No.
So to take a moment and really assess if you do need to see a physician.
Right. And, you know, when I was diagnosed with sleep apnea, I was sitting at the nurse's station, sleep, you know, but I was not thinking, you know, why am I sleepy? I'm a doctor, I'm busy, I do a whole lot. I got a really busy life. That's why I was tired all day. I mean, that was what I told myself. Mm-hmm. And it was another doctor had to walk by and say, you know, you have sleep apnea, probably because I was sitting there snoring at the same time. And so it's just, so even with doctors, it's hard to recognize something in you, you know, versus others, which is why you go to a doctor to try to tell them how you feel. It may be insignificant and say, well, you know, that's nothing, you're just getting old. Or maybe, oh man, you might have something.
Well, I wanted to take a time to highlight your link, the link to your website. So it's drgreghall.com, drgreghall.com. The site includes an archive of your latest publications, specific to the health and wellness of the African American community. And I just want to, thank you for what you do day in and day out.
I appreciate it. Thank you. No problem. And thank you for what you do. I mean, this is a great opportunity for everyone to kind of learn more about our culture.
Yes. So thank you for joining me today. We'll make sure this video is available with other information on the center's website at caahealth.org. And during our next Facebook Lunch and Learn, we will address your questions about the COVID-19 vaccine. So join us on January 21st. Have a good day.